Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Rebecca Sath. I am a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy immunology. Our podcast series will use interviews with thought leaders from the world of allergy and immunology to keep you up to date on new developments and to review core topics. Today's edition of our Conversations from the World of Allergy podcast series will focus on the topic of allergic reactions to stinging insects. We are pleased to welcome Dr. Karla Adams. Dr. Adams is an associate professor of pediatrics and a practicing allergist in San Antonio, Texas. She is also the program director for the Allergy and Immunology Fellowship at Wilford Hall Ambulatory Surgical Center in San Antonio and has a specific interest in stinging insect hypersensitivity. Dr. Adams, thank you so much for taking the time to join us today.
Hi, thank you so much for having me.
We like to start by getting to know our guests a little bit better. Can you tell us a little bit about yourself and maybe something you like to do outside of medicine?
Sure. So I am an Air Force allergist. I'm stationed in San Antonio, Texas. Completed most of my training in the military. I went to the Uniformed Services University in Maryland and then did PEDS training and then allergy fellowship here in San Antonio. Did a short stint at Nellis Air Force Base. And then I've been back in San Antonio since 2016 and I'm the program director for the fellowship here. I guess outside of work, I love to travel. My family and I enjoy the outdoors. Took up hiking in the last few years, and just I guess over the last 6 months, have recently started to do more cooking with like traditional family recipes, and it's cool because we can involve the whole family with that project.
Oh, that's great. What is hiking season in Texas?
So it's pretty much year round. Like I said, we've actually even gone during like the few times where it's actually cold in Texas. So you just bring some extra sweaters, just because it's cold in the morning, but usually by midday to afternoon, it's beautiful weather. So you can actually hike year round, which is nice.
Yeah. And very important for someone who's an expert in stinging insect allergy out among the stinging insects. So there you go.
There you go. Yes, definitely.
So what made you choose allergy immunology as a field?
Yeah, so I think my interest started as a fourth year medical student. I got to rotate through the allergy department at Wilford Hall and just really loved just the everything that involved allergy, right? So the complexity of some of the conditions, the fact that we treat so many different conditions, the continuity with patients was also really cool. Just being able to follow, pediatric to teenagers to adults, and kind of helping them through their allergic conditions was very exciting for me to like delve more into and learn more about. PEDS training was great, but I definitely knew that I wanted to subspecialize, and always allergy was always in the back of my mind. And luckily when it was time to apply for fellowship, they accepted me. So here I am.
Would you say there's anything different about doing allergy immunology within the military setting versus kind of in a general outpatient setting?
Yeah. I mean, for the most part, it's the same. There are a couple of differences or caveats. In the Air Force, the allergist is responsible for kind of the readiness mission for us is really immunizations. So we spend a lot of time talking about immunizations, how to do it safely, how to run large scale immunizations, like processes. So like our fellows get a lot of training in that, which is not something that you typically see outside of the military. But again, the reason we have allergists in the military is for that readiness mission. So a couple of caveats, but it's definitely still within the realm of allergy and immunology.
Yeah, no, I imagine that's such an important the immunizations, particularly having just gone through the pandemic, knowing how we distribute and kind of do that wisely.
Yeah, definitely. Yeah, COVID was an exciting time for us, starting vaccine lines from scratch and whatnot. So, obviously a scary time as well, but all that training really came in handy.
That's wonderful. Today we're going to talk about stinging insect allergy, and stinging insect allergy for us in allergy comes up all the time in practice, particularly as we head into these summer months where people are out and about. let's say a patient comes in after a sting with symptoms that they or their physician are concerned could indicate an allergy. What type of symptoms do you want to make sure we ask about, and what information about the setting would be helpful?
Yeah, it's a great question. So I think the key distinction to make early on is what's a routine reaction, right? Like what can normal patients who get stung expect, and then what happens when symptoms go beyond that. So most patients that get stung by an insect are going to have a local reaction, so itching, redness at the side of the at the sting, typically resolves over a few days, not much to worry about. Some patients can have really robust local reactions. We call those large locals, well, which can be pretty cumbersome because they've got more swelling, more redness kind of at that site. The scary reactions for us are going to be anaphylaxis or whole body systemic reactions. And that can vary from cutaneous symptoms, so itching, redness, that's involving your whole body, to respiratory symptoms, difficulty breathing, coughing, cardiovascular symptoms, palpitations, decrease in blood pressure, or even gastrointestinal issues, so vomiting, diarrhea, and whatnot. And obviously, the combination or constellation of all those symptoms is what we want to ask about when patients get stung. And if they answer positive to those symptoms, then we want to get them evaluated by an allergist so that we can consider testing and then potentially start treatment for them, which is venom immunotherapy. I think the important questions to ask is the historical questions around the sting. So, what was the patient doing? Where were they? So, were they outdoors? Were they were they eating? Were they around food? Because some flying insects tend to and be around those locations. For I'm in Texas, so fire ants obviously is a big deal for us here. So questions that we specifically want to know about is, did you see any pustule after the sting? So fire ants can cause a pseudopustule that starts within a day or two after a sting. So if we see the pustule or the patient tells us that there's a pustule, then again, that can give us hints that it was probably a fire ant sting that led to that reaction.
Can you remind us where in the country we tend to see fire ants?
Yeah, definitely. So definitely across the southern US, so southeast as well as south central, small area in California, but overall, Texas, think southeast states. There's, the line is probably around the Maryland area, although there are some fire and hybrids now that can tolerate some colder weather. So luckily, the U.S. Department of Agriculture has done a really good job of setting up quarantine zones to prevent further spread.
Yeah, we're hoping we don't end up with them up here in the Northeast, but we'll see. And can you tell us a little bit more about the different kinds of stinging insects that fly, that we should be worried about, and the way we might help our patients know what kind of insects they might have been stung by?
Yeah. So there's five kind of big species that we worry about in the U.S. Obviously, each location is going to be a little bit different, but the five big ones are honeybees, yellow jackets, wasps, and hornets. And then there's two different hornet types that we talk about: the white-faced hornet and the yellow hornet. Some of the historical like pieces that or information that you want to get is things like honeybees tend to be less aggressive than the others, but if you're disturbing their nest, they can be aggressive and they can sting you. They can leave a stinger behind, so that may be a historical clue that a honeybee stung you. Yellow jackets are very aggressive. These are the ones that are typically found near like where humans eat. So picnics, if there's trash cans, they scavenge for food. So again, another clue that it might be a yellow jacket that stung you. Wasps are usually found around the eaves of patios and houses. Typically, these can be recognized by a very narrow waist. They kind of have dangling feet, if you see them flying. And then hornets are usually larger, a little bit more aggressive as well, and they can be in trees or shrubs as well. So, again, these are some historical clues that might point you in the right direction in terms of what possibly stung that patient and whatnot. But really, it's just gathering that full history is going to be really important.
And given that can be difficult to identify the exact species, we tend to, if there's been a reaction test to all of them, just because that historical information can be misleading sometimes.
Oh, yeah, correct. Yeah. So unfortunately, patients and providers, including allergists, are not very good at identifying, the yellow stripy flying things, right? So you're right. We typically test to all the flying insects if that's the concern.
And are those the same stinging insects that we see worldwide?
In general, yes. I do think there are certain locations where you might see prevalence of one more so than others. There are things like there's a Mediterranean wasp that is not just in Europe. Actually, there's actually some here in the U.S. as well. Trying to understand what it's our job obviously to find out which of the prevalent stinging insects are in our location. But like you said, because it's difficult to determine what stung patients, we tend to kind of focus on the the more likely ones, and then the ones that we have commercial testing available to as well.
Now, large local reactions we know are not systemic reactions, but they can still be really unpleasant. So, how do we approach our patients when they've had these really huge, large local reactions to a sting?
Yeah. Yeah. So great question. Like you said, these can be very cumbersome as well. In general, it's going to be supportive care. So one, it's, reassurance. So yes, they're going to be cumbersome for 24 to 48 hours, maybe a few days, but they'll start to go away on their own. So you want to just supportively treat through them. Oral antihistamines can help if there's itching or swelling. Non-steroidal anti-inflammatory drugs can help as well if there's pain associated with it. Simple things like ice packs, elevation of the extremity if that's where the large local reaction happened. And then for really extreme cases, a short course of oral corticosteroids may be reasonable, especially like if someone is having difficulty ambulating because they were stung on the leg and whatnot. You could consider that for some of those patients.
And over time, the recommendations for patients with only cutaneous symptoms has changed. What are the recommendations now if someone only has skin symptoms and that's it from a sting?
Yeah, so great question. So these are patients that only have hives, swelling, flushing after a sting. They might, those are systemic symptoms, so they have hives all over. In the past, we used to think that that could indicate a higher risk of reaction, but over the last decade or so, there's been new data, studies that have shown that that risk is actually low. So somebody that has a systemic cutaneous reaction has about a 10% chance of having a recurrent future systemic reaction that is usually going to be cutaneous only with future stings, but only like less than 3% of those symptoms are going to be anaphylaxis or severe. So we actually consider that to be low risk. And right now, the recommendation is actually not to test, meaning doing skin testing and not to offer venom immunotherapy because that risk is considered to be low. Patients that have anaphylaxis, so full body systemic reaction to stings, their risk is much higher, so 30 to 60%. So in general, systemic cutaneous symptoms, we would also treat supportively. Now, I will caveat that the approach can be individualized. So in patients that have recurrent systemic cutaneous reactions, so think beekeepers, folks that can't avoid those exposures, you could consider testing and treatment. But again, that's a nuanced case by case kind of situation.
I think the practice parameters also has similar kind of nuance to people who have very large local reactions that are really impactful on their quality of life and are going to be stung like these beekeepers or someone who's a gardener who's going to be outdoors all the time.
Correct. Yeah. So I think that it's important to take that individualized approach, and it's also shared decision making with those families or those patients as well.
Yeah. Now, how do we consider adults versus children and their reactions?
Yeah. I think it's important to know that, like, fundamentally, the evaluation for venom allergy in kids and adults is the same. So we still want a history, right? So that's going to be paramount. After the history, then we talk about testing and treatment. And I do think there are some differences, more so logistical differences that I think are important to keep in mind. So just thinking about young children that perhaps may not be mature or may not be older, right? Where they are able to sit through something like intradermal testing becomes really important. So in those situations, that may be a consideration for serologic testing first. So starting with lab work in those individuals versus skin testing to see if you get an answer before subjecting the patient to a more invasive test. I would say that I think we all have had some adults that might also fit that criteria, right? Whether they're needle phobic or somebody that, let's say, is dermatographic, where you're not able to do the skin testing against serology testing, might become important there. When it comes to treatment, again, I think the ultimate goal is if you've identified venom allergy, we want to get them tested and we want to put them on treatment. So this includes pediatric patients. But I think there's, again, chance for nuanced approach to kids. There's some data that points to the safety and efficacy of a lower maintenance dose in kids. So standard maintenance dose for everybody with venom allergy, it's 100 microgram of venom extract monthly. But in kids, 50 micrograms has actually been shown to be effective and efficacious and safe as well. So again, it allows you to perhaps take a more of an individualized, nuanced approach in those patients if it's needed.
Absolutely. And so when we're evaluating this patient who came in, whether it's a kid or adult, who came in after a sting, had a reaction, which we are calling a systemic reaction, we can send blood testing or serologic testing. We can do skin testing. How should we approach this? Is one better than the other?
So great question. I think historically, skin testing has always been considered to be the more sensitive test, and I do think early on with serology testing, which initially was the RAS test, that test did have lower sensitivity than skin testing. But over the last few decades or so, serologic testing has actually had a lot of advances, making the test comparable regarding sensitivity. The last stinging insect practice parameter actually uses that verbiage, that language to talk about both tests. So I really do think we should think of both skin testing and serologic testing as comparable tests. It's important to realize that you're going to have patients that are going to have negative tests to a skin test or negative serology. So the nice thing is you actually have a backup test that you can do because that risk of venom allergy is so high. We want to make sure that we identify the correct venom so that then we can treat the patient with immunotherapy, which again, it's nice. We have two tests. I think it's just making sure that we take those personalized or the individualized nuances to figure out which test is better for that patient in that situation.
I know that you can get false positives with the particularly the serologic testing if you've been stung, that, something like 40 to 50% of patients can have some positive testing initially after a sting, even without a systemic reaction. How do you think we should approach this to make sure we're not getting those falsely positives?
Yeah, great question. I think with any medical test, right, they're going to have some pitfalls. I think, false positive testing, some of it is related to the actual venoms themselves. So there's a lot of cross reactivity. A lot of these insects are all members of the same like Hymenoptera order. So there's cross reacting proteins that are very similarly. So our testing might pick up kind of that cross reactivity. There's also cross reacting carbohydrate determinants, which are plant antigens or epitopes that might also be impacting some of that cross reactivity as well. How you do the test is also important. So, skin testing with really concentrated venoms can also cause false positive testing. So, it's important when you're doing skin testing to stop at the 1 microgram per ml concentration because if you use concentrations higher than that, you might have false positive testing. On the flip side, there's also concern for false negative testing. After a sting, there's thought to be a refractory period in some patients where you've released all of your mast cell mediators. If you were to get skin testing, within weeks of a reaction, you might have negative skin testing. So, again, consideration for repeat testing is also important. There's variability in test results. So lots of issues that go along with the testing and whatnot. And I think it's important to realize that there's issues so that when you're interpreting the test, you know exactly, how those issues might impact your interpretation.
Yeah, no, as you said, as everything in medicine, every test has positive and negative predictive value, and we have to use the history is so important in kind of determining what we do with the information that we get. Yeah.
Yeah,
So
definitely.
one of the recent recommendations is for those patients who have a systemic reaction to measure tryptase. Why was that added to the recommendations?
Definitely over the last decade or so, I think we've started to try to identify biomarkers for risk, right? Not just for venom allergy, but for other allergic conditions. And tryptase has been one of those lab tests slash biomarkers that we have identified that can be helpful in terms of predicting risk. For venom specifically, elevated tryptase values, and we're talking baseline tryptase. So not after a reaction. But those elevated values are associated with other conditions such as mast cell disorders, conditions like hereditary alpha tryptosemia, which can co occur with venom allergy and unfortunately increases the risk profile for patients that have venom allergy with one of these conditions or both of these conditions. So that means that those patients may be at higher risk for having reactions, more severe reactions, as well as failing treatment. So identifying those patients early on can be really helpful in terms of the management of their venom allergy, as well as the long term prognosis for those patients. Even outside of mast cell disease association, an elevated tryptase can also just be predictive of reactions to immunotherapy. So, in my case, or in my clinic, I use that tryptase to help me risk stratify patients when we start talking about how we're going to put them on immunotherapy. Just because if, knowing that an elevated tryptase might mean they might have more reactions to immunotherapy, that helps to guide how I'm able to put them on immunotherapy. So, again, it's just an additional piece of information that is helpful as we're evaluating patients.
And with the serologic testing, they're introducing more and more of us are having access to component testing. I think it's become more
Mhm.
common in Europe and it seems to be becoming more widespread here. How should we use component testing for our insect allergies?
Yeah, great question. So, yeah, it was FDA approved in 2020 for components in the US. I do think more folks are using it, which is good. I think it's a great test, but it does have some limitations. We'll talk about those in a second. I think just to start component testing, what it is, it's we're looking for specific IgE to venom components. So, typically, serology testing, you're looking for whole venom IgE components is those individualized and venom allergens that you're looking for IgE for those. It can help with cross-reactive antigens. So we talked a little bit about. Patients that present with multiple positive venoms, but maybe one sting and one reaction. So then you're scratching your head trying to figure out, well, what was the true cause of their reaction? And that's where component testing can come in. I think the limitations are important because unfortunately, right now, we don't have components for all the venoms that we worry about. So, current commercial components are helpful to distinguish between honeybee and yellow jacket allergy, but unfortunately, we don't have all the components to differentiate between, say, a yellow jacket and a wasp allergy. So, over time, we might get to that point. So, again, at least at this point, you want to make sure that you understand kind of what those limitations are. The other piece that I'll mention is I think early on with components, the thought was that they were going to be more sensitive than whole venom testing. It actually turns out that they are more specific, but maybe not as sensitive as that whole venom testing. So over years, we've actually realized that we need to do panels of components to get to that same sensitivity. So again, it's just that nuance of testing is important as we evaluate these patients.
Yeah, I think part of the hope is that it can decrease us using as much venom for immunotherapy if we can really target it to what the patient was stung with and had a reaction versus this cross reactivity and maybe including more venoms than we need, particularly given the history of shortages of venom for immunotherapy.
Yeah, great point. Yeah, exactly. And the cost as well, right?
Oh, yeah,
Sometimes it can be a costly endeavor. So,
absolutely. And then what are the different so we've decided our patient needs immunotherapy because of they have a history of a systemic reaction, they have positive testing. What are the methods of immunotherapy that can be used? We have traditional, we have rush, we have this cluster immunotherapy. Are there any differences in their effectiveness or their safety?
yeah. So there's multiple buildup protocols, and a lot of these follow what you would normally do for like air allergen immunotherapy. So traditional protocols or conventional buildup protocol. Typically, these are protocols where patients come in once or twice a week. They get one injection, and then they come back the following week for the next updosing. Cluster protocols would be where you get multiple injections in one sitting or one day, and then a week later, you would say repeat another set of cluster injections. Rush immunotherapy is giving multiple doses, maybe over the course of 2 to 3 days to get to the maintenance dose. And then ultra rush would be essentially starting and finishing your entire buildup in the matter of hours. So, very fast protocols to get to maintenance. I think the important thing to remember is that protection against future stings is actually reached once you get to maintenance. So you could argue that for venom, if we're saying that this is a high risk condition, we want to get patients to that maintenance dose as fast as possible. So again, accelerated protocols, I do think they do have a role to play when it comes to treatment for our patients. Reaction rates vary, but in general, It's actually the ultra rush protocol, so maybe are associated with slightly increased risk of allergic reactions. Here in San Antonio, we do a lot of 1 day fire ant rushes, and we have certain protocols. We typically pre-medicate, and that's usually just enough to get our patients through the entire rush protocol without any issues.
Yeah. No, especially in stinging insects, getting to that protective dose can be really important, especially if they were stung in the middle of the summer and we're trying to get them back out there to be able to be safe. Yeah.
Right. Yeah. Especially again, like places like here in Texas where you go outside and could get stung. Right. It becomes an urgent matter to try and get to that protective dose.
Yeah. And one consideration we often have to address, especially in our adult patients, is this issue of cardiac medications, particularly the beta blockers and the ACE inhibitors. And kind of, I know thinking has been changing over time in terms of risk. How should we approach these medications when there's a history of a reaction? We're discussing immunotherapy and they're on these medicines.
Yeah. So yeah, definitely kind of that's been changing over the last few years. I think historically there's been reports of patients that maybe are have been at increased risk of not just having reactions but also severe reactions to venom as well as other allergic triggers if they're on antihypertensive medications. And I think some of the like inconsistency in terms of the results with some studies showing no change versus some studies showing risk is that there's different populations that we test, right? The other kind of underlying concern or question that remains is just the risk of, say, cardiovascular disease in patients that are on antihypertensives, where perhaps it's actually the cardiovascular disease that puts patients at increased risk. But when we're doing these studies, it's really hard to tease apart the two things. Is it the underlying condition or is it the medication? There's actually been some newer data. There's one large prospective trial out of Europe in the last few years that actually enrolled venom immunotherapy patients or venom allergic patients who then received venom immunotherapy. They followed them and they actually saw no increased risk of anaphylaxis to treatment or to field stings. The efficacy of immunotherapy was also unchanged in those patients. So I do think we've got some venom specific data now that maybe points towards the safety of continuing these medications. In venom allergic patients. And the 2023 anaphylaxis practice parameter actually has a really nice section that talks about some of these studies. And currently, the recommendation is actually to have a shared decision making conversation with your patients in terms of, if they are on antihypertensives and they have venom allergy. We just need to discuss kind of the pros and cons of continuing those medications or starting immunotherapy or continuing immunotherapy. I will also point out that if somebody is on antihypertensives because of cardiovascular disease, there's also a risk of stopping those medications, right? So it's not just the risk of continuing immunotherapy. There may be underlying risks. So I think it gives us an opportunity to have that discussion with patients, in order to treat both conditions, if you will.
Yeah, no, absolutely. As allergists, we get so focused on the risk of the stinging insect that we sometimes forget how important these antihypertensive are to their cardiac disease and how it's lowering their risk there. And so I love the new introduction of shared decision making in the setting of this new data that maybe it's more of a balanced decision.
Yeah, yeah, I
Mm.
agree.
And what are some possible strategies to consider if a patient does have a reaction while they're on immunotherapy?
So I think finding out where when they had that reaction is important, just because you might do something different depending on whether it happened during buildup or maintenance dose. So if the reactions are happening during buildup, again, we've already said we've identified this patient needs treatment, so we're going to try our hardest to get them to that maintenance dose. If they're doing conventional buildup, actually switching them to a more accelerated schedule is one of the things that you should consider, and part of the reason is that you can consider things like pre-medication. You can do that with traditional conventional buildup as well, but with rush immunotherapy, if you pre-medicate them and you can get them to that through buildup to that maintenance dose in that one sitting, that can actually be associated with lower risk. Other kind of medications that have been tried have been biologics. So omalizumab has been helpful for some patients as essentially pre-medication, sometimes a bridge to get them through buildup to get them to maintenance dose. So definitely an option to consider. For patients that react while they are on maintenance dose, then traditionally we would cut back and then try building them back up. You can either do that conventionally, or if you wanted to, again, this is where you could try rush immunotherapy. Patients that have reactions on maintenance dose, I do want to just caution these are typically patients that might be at increased risk for failure of treatment. So those are the patients where we start talking about maybe they need a higher dose of maintenance immunotherapy, or maybe indefinite therapy down the line as well. So there's some changes that you can make to their schedule.
Yeah. I'm curious, they're doing these studies on BTK inhibitors before food allergy and OIT, and it'll be interesting to see if that's something that could be used in some of these. It is a rare case that someone has these systemic reactions on immunotherapy, but that might be an option. Certainly not studied yet, but it's something to think
Yeah.
about down the future.
Yeah, definitely. I mean, aside from BTKs, other biologics as well. So I think the field is ripe for, potential advances using biologics.
Absolutely. So, how long should a patient be maintained on immunotherapy? How do we know when we can stop? People often ask, do we need to do testing? What do we need to do? So, no.
Yeah. So, in general, it's going to be 3 to 5 years. 5 years tends to offer, maybe ideal or more protection, if you will. So, I would definitely, typically, my venom patients, I keep them on for at least 5 years. And then it also goes back to risk. So, in patients that have kind of high risk factors, again, think mastocytosis. I had a reaction on immunotherapy. I had a reaction to a field sting on immunotherapy. Those patients, the discussion is typically indefinite therapy, because the concern is that they're at high risk for failure or recurrence of symptoms with future stings. So you want to do that careful risk assessment for your patients to help make that determination. One of the questions that I think I get sometimes is the utility of repeat skin testing or serology testing to decide whether or not to stop immunotherapy. And in general, it's not very helpful, because your serology or your skin test may not necessarily change during treatment. There's some studies, it's mixed results in the studies that have been done looking at this. So, in general, repeat testing is not going to help you make that decision. It's going to be clinical history as well as how long they've been on treatment.
Yeah. No, and I try to talk to my patients about all the other tolerance mechanisms that we're developing that we can't see just by skin testing. But it would be nice if we had a test to say, now we know you're protected. And unfortunately, that's just not available.
Yeah, agreed. Yeah.
Yeah. Another question I often get is from my patients, they've done their 5 years of immunotherapy. I think they can stop. And they say, do I still have to carry this EpiPen around with me, or is it possible to get rid of it? What do you think? What would be the recommendation?
Yeah. Oh, great question. So, I think that in general, so again, it all goes back to risk, right? So, somebody who has not been on immunotherapy, please carry your EpiPen, right? We're worried that you could have a reaction. So, definitely to carry an EpiPen. In patients with those high risk factors that I mentioned, those are patients that even if they've done, their 3 to 5 years of immunotherapy, and even if they continue that immunotherapy, or they decide to stop it, those are the patients that I might consider recommending that they continue to carry an epinephrine auto-injector, just because they're at high risk for relapse. So we want to make sure that they remain protected. If you have a patient that is currently on maintenance immunotherapy without any of those risk factors, I do think there's a little bit of room there for shared decision making about whether or not to continue to carry while they're on treatment. Epinephrine is associated with anxiety, just having the prescription, perhaps decreased quality of life as well, the costs associated with it. So I do think there's a little bit of room to have that individualized approach with patients, again, depending on where they're at in treatment.
I think it also depends on where they're going to be when they might be stung. And so I have some patients that are backpackers that are out, way beyond where it's going to be very difficult for them to get to medical attention. I imagine you in the military have similar patients that we really still want them to have that available, even though the immunotherapy is really lowering their risk. We know that having that available is just a precaution.
Yeah, I definitely agree with that.
Yeah. And do you know of areas of active research going on in the stinging insect field?
Yeah, yeah, lots of different areas or topics that I think are currently being investigated. So I think I've touched on some of the kind of gaps that remain in our knowledge. So things like, what's the ideal test, right? Is it skin testing first versus serology first? So looking at maybe just the order of testing. I know there's some researchers looking at those areas. I think identifying biomarkers is important as well. So we talked about tryptase already, but getting a KIT DA16V mutation testing that's been identified recently as another biomarker for not just venom allergy, but kind of the venom allergy mastocytosis kind of connection as well. And in our population, we see a lot of non-adherence, and some of that is just our population that's very mobile. But looking at accelerated testing protocols as well as extending maintenance intervals is also important. I think just to kind of help with the adherence piece, and again, providing effective treatment for patients that's also safe as well. So I think lots of exciting areas that are currently being looked at for venom allergy.
That's great. Yeah, hopefully we'll have, especially those biomarkers would be so helpful for our patients. So, one of the things that inspired this podcast is that you were recently involved in a work group that really evaluated the education of fellows on stinging insect allergy. And the work group found that fellows are just not getting as much exposure to venom allergy evaluation and treatment as they might need based on what physicians who are in practice see. What can we do to improve this? How can we improve our fellow education in stinging insect allergy?
Yeah, so definitely a great question. I think this particular question kind of marries up my two interests: fellowship, education, and training, as well as venom allergy. So, yeah, I think there was a keen interest from the anaphylaxis or the insect allergy subcommittee for the Quad AI anaphylaxis committee in terms of trying to figure out whether or not our fellows are seeing enough venom allergy patients during training. And while the vast majority do get some exposure, I think it was important for us to identify kind of the gaps in the education and barriers. I think numbers is important. So fellows, in general, over a 2-year course of fellowship, they're seeing maybe 1 to 5 patients with venom allergy. And when we looked at folks that are in practice, some practices or some allergists are seeing 1 to 5 venom patients per month, some even more than that. So again, there's a vast difference in terms of what you get trained to see versus what you're actually seeing in real life. I think just kind of through our discussion, hopefully you get the sense of just the nuanced approach that you need for venom allergy. And it's really hard to get at or to teach all those nuances when you're only seeing 1 to 5 patients over the course of a couple of years. So I think just increasing the number of venom allergy patients that our fellow sees is an easy approach to getting them comfortable with this topic. It doesn't necessarily have to be the patients themselves. Obviously there's geographic differences between fellowship programs, but I think even just exposure via case studies or talking to the experts, attending educational sessions like at the annual meeting is important. Just a plug, our subcommittee is actually working on a uh, fellow and training case like theories that's been put together from experts kind of across the field. So it's close to being done. So once that's available, again, that would be another way to get your fellows or the fellows and the trainees exposed to this really important topic.
Yeah, and it can be so variable even just in a fellowship as a fellowship director as well. It can be so variable in a fellowship. So it might just so happen that one of your fellows sees a bunch of cases just because they happen to have gotten those. And then the other fellow doesn't see as many. So I love the idea of making sure that it's presented in case conference, that there's discussions about it, that it doesn't have to be just based on the patients they see in clinic, that it can also be done outside of that.
Right. Yeah, completely agree. And then again, it's through like those cases, right, that you learn some of these nuances about testing, pros and cons, all the things that we discussed today. So I think that exposure is important for all our trainees.
Yeah, and I love that there's gonna be kind of a case series that we can direct our fellows to, at the Quad AI. Do you know what the timeline is for that? Is it likely to be available in the next, 6 months to a year, or this is down the line?
No, so great question. So we've been working on it for about a year or so. I want to say that all the cases have been compiled. I think some is just the logistics of where that document slash those cases are going to live. So I think it's the logistics. Hopeful that in the next 6 to 12 months they'll be published for everybody to use.
Fantastic. Well, hopefully this will also provide education for our fellows on stinging insect and things to consider. Are there any, take-home points or things you wanna make sure that we follow up on?
Yeah. No, thank you so much for the opportunity. Obviously, I think a really important topic, and like you said, very timely with summer coming up as well. I am happy to answer any questions. I have folks email me with cases and whatnot, so I'm happy to continue that conversation offline as well.
Right. Thank you so much.
Thank you.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at their website. Please visit quadai.org for show notes, including the practice parameters on stinging insect hypersensitivity and other pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast and to review so you can receive new episodes in the future and let us know what you think. Thank you again for listening.